Okay, so I'm going to start a little bit about the AMC 2 exam, and these are the few things that I'll be covering today. So we'll be touching on the different core subjects. I'll explain to you the number of cases that usually comes out in these different subjects. We're talking about the scoring system. Now, scoring system, I will be showing you sample results for those who have allowed me to show your result slip. So thank you to those candidates previously who have allowed me. And I will be sharing resources as well, and I'll be guiding you to links which you can use. This session will be most beneficial for those who just booked their exams. But those of you guys who are having your exams soon, or you're doing your second seating, please focus a little bit more in the scoring system part, because that's where when I reset from my AMC2 exam after not making it the first time, focusing on my result slip and knowing where I went wrong was 100% the reason why I think it was way easier to make it the next time round. Is there any way AMC 1 is beneficial in pleb? Oh no, you gotta sit for pleb 1, then pleb 2, man. Doesn't work that way, unfortunately. All right. So first of all, before we even start, right, we need to know what AMC2 is. We need to know our demons. We need to know who we are tackling in this exam, right? So first, it's an OSCE exam. So it's oral, structural, clinical exam. So oral means a lot of speaking involved. In the OSCE itself, there's the word called structural, which is why a lot of us focus on structure because that is what the exam is looking out for. Now the exam is done in Melbourne face to face. Last time in 2024, there was the online version of it. Now it's face to face, and the online version is very little, guys. It's only offered mainly for your GPs in the rural side who are not able to really come over to do the exam, and it's very limited. At this point, face to face is the only way to go for this exam. All right. Now, the pass rate for this exam has been getting lower and lower and lower, unfortunately. But please don't get overwhelmed by them. All right. The numbers are really scary, but it is not an impossible exam. It can be done with strategy and with the right approach and the right support. You can definitely do it. And every attempt at the end of the day will make you a better clinician. And that's what it matters at the end of the day. And I have so many candidates who come and tell me, Love, I feel like, I studied more for AMC2 than I ever did when I was studying for medicine school in the 5 to 6 years of med school, which is very true because I actually felt the same thing. I was like, wow, I feel like I learned like 6 years of knowledge squeezed into like 3 months or 5 months right before I do my AMC2. I don't even know if I would have been this competent after medical school, unless if not for the AMC2. So think about how far you've come as well. Don't just look at the grades, don't just look at the results. I'm sure you guys have improved drastically through every attempt that you sit for. Now, this exam has 14, all right, 16 stations. Sorry. Out of the 16 stations, you have 14 squad stations and you have 4 rest stations, making a total of 20 stations for you. And you need a total of 9 passings. Now you have 2 pilot stations. Many people ask me, Love, will I know what is the pilot station? The answer is no. You will not be able to know until your results comes out. Sometimes the changes in the questions are very subtle. The AMC is either trying to refine the task a little bit, or the AMC is trying to just adjust the symptom, adjust the approach. So you will or adjust the timing of the exam. Like maybe instead of a 5 minute prompt timer, they want to give a 6, and they still want to see if candidates are able to finish the station in time. So no, you will never really be able to know what is the pilot station. So give your best shot in every station. And if something happens on that day and they decide to scrap a squad station, they will use your pilot station to score all of you. So don't take any chances at all. Always nail for the 16 stations that you are scoring for. And people asked me, last time it was 10 stations to pass. Now it's only 9. Does that mean it's easier? And I'm very sure some of you guys are smiling behind the screens. So no, I don't think it has gotten any much easier. The marking scheme is still the same. It is still not very easy to clinch that 9, even though in the beginning we did see higher number of passes. Now the number and percentage seems to be very much similar to how it used to be before the whole 10 points are made. And now what the AMC is doing is what we're going to explore a little bit later is that they are changing their task a little bit. They are adding in a lot of new words. So, for example, in the past, maybe they just said mention diagnosis and differentials. That's all they asked for previously. But now they are focusing on asking you, give your diagnosis and differentials with reasons, with causes, or they are telling you, give the implications of the diagnosis. They are making it a little bit harder, to be honest. And in previous times, there wasn't so many drawing or writing from what I've noticed. Now we have medication charts. We have even for the breast PE exam that's coming out, you have to plot the circle and plot the nipple and indicate the findings that you have gotten. So more hands-on, I would say this time round. I do see ISBA presenting very often as well. MSc appearing very, very often. It wasn't really the case previously back in 2023 or 2022. So those are the changes that we are seeing. So it gets a little bit more difficult. But one thing is for sure, you need to know that we are not specialists at the end of the day, which is why I always tell you guys, Pete's, OBG, and psychiatry have a little bit of like a lower threshold for passing compared to med search and physical exam. They expect every one of us to be top notch when it comes to med search questions and physical examination stations. Very it's something that I would expect of any doctor to be, but because I know that we're not pediatricians, ONG, and psych, I wouldn't expect you to give me 100% in those cases. As long you're able to touch on the key points and not miss critical errors, these stations are a little bit more easier to pass. So these are the average of the number of stations that has been coming out in recent times. So as you can see, MedSearch still holds your biggest weight in the exam. So you need to make sure you tap on medicine surgery. And even though Pete's, ONG, and psych seems to be a bit more lesser, people are like, then I can study that very last minute. But I'm going to tell you, it's so easier, it's much easier to pass those stations. So please do not neglect Pete's, ONG, and psychiatry. Spend some time doing them because threshold is lower, easier to pass, easy to get that points for you. And in this exam, I have people who are telling me, oh, love, I'm only going to do message and PE. I'm not going to do Pete's, ONG, and psych. Not the wisest way to strategize when you're doing this exam. Please get better strategies, start a little bit earlier, give a good amount of time for all the different core subjects. I mean, if you give 3 hours for med search, maybe 1 hour for PETS, 1 hour for ONG, 1 hour for psych, that should be the ratio of how you are doing this exam. Okay, I will dive into every station later on. Okay, guys, I'm just going to spend some time talking about the different tasks that are out there. So these are all the various tasks. But before I dive into them, I'm going to explain a little bit about the prompt timer, which many of you seem to be a little bit confused. So most of the stations have a prompt timer. So far, I've asked most of the candidates. All of them have prompt timers. It's just that the prompt timer differs. It can be 4 minutes, it can be 2 minutes, it can be 6, or it can be 7. And the prompt timer will be given to you in your room, in your station. The examiner will tell you that this is your 5-minute prompt timer and you will hear a bell. So some of us used to ask me, oh, love, is it like a universal timer for everything? No, every station is different. And if they say prompt timer, that means that you on your own will be like, okay, I've finished 5 minutes. I'm going to move on a little bit. I'm going to ask a few more questions and then I'm going to move on to the next task. That is what you can do. That is one way of how the exam question comes. But there's another way the exam question comes. It will tell you, take history for no more than 5 minutes, for no more than 4 minutes. If they say that, it means that you are not allowed to take any more history-taking questions after that time prompt timer. And if that's how your stations are, it means that you need to ask all your key questions, all your red flags right at the top, right from the beginning. Right? That's something to take note of. If you look at the handbook, you will be a little bit more familiar with the different kind of task that's out there. Okay, so that is history taking. Now we move on to a little bit on PFE asking. Now PFE stands for physical examination from the examiner. I have done a session on PFE before, I think about a month or two ago. It is not on the YouTube link hub. So when I do it again a little bit more better, I will post it onto the YouTube, or if I do it on my own, I'll just post it for you guys. But PFE, please try to be very, very structured on PFE. When you are being marked in your domains and your scoring, there is one particular one for accuracy and choice of investigations and structure. of physical examination. And even though it's a history taking station, what they mean by that is marking you on your PV station. So it comes in a couple of ways. I had a case on delirium for post-op patient. So one, PE card can be given to you in certain stations. In certain stations, it will be asked to give 4 minutes from the beginning. So no history at all. You're given a very long stem and they tell you you have 4 minutes to ask your PV from the examiner. And the remaining 4 minutes is for you to discuss with the role player, with the patient, or with the relative on what the diagnosis can be. These are different ways how your PV station comes. There's also ways where they tell you take focused, relevant physical PV from examiner, PE from examiner. These ones you have to exactly know what you're looking out for. In those stations, you will be ruling out your red flags and confirming your diagnosis. We did a couple of stations before within the handbook case, the syncope case. And if you look at the critical errors and red flags in the handbook of the syncope case, very important to tap your buoys, tap on your carotid, find for murmurs, know the character of your murmurs, check for any kind of neuro deficits. That will be your critical error for a syncope station in PV. So look at the handbook. I know I promote the handbook a lot because I always say that that's the only golden answer given by the AMC, which means that's how we know that's the way their thinking process is and how they want us candidates to think about it. All right. Otherwise, your PV can also come up. PE in general can come as interpreting investigations. So under interpreting investigations, they give you chest x-rays, they give you CT scans, they give you ECGs. Urine dipstick has been started to be given, spirometry, growth charts as well. All of this tends to come. NIPT test results also falls under interpreting investigations. So please familiarize yourself with looking at different investigations, learning how to be able to explain that in layman's term. So when you do an x-ray, I always tell you guys very basic. Look at the colors first, tell them what is black, tell them what is white, so the air and soft tissue and the bones. Once you have done that, show them what is normal first. So example, if it's a pneumothorax chest x-ray, show them the normal side, show them how a normal lung looks like, show them the peripheral vasculation, the markings going on there, and then tell them, look at this side. Told them that, do you see that there's no air going in? It's really, really black. There's no vasculature going in. This is what we call a pneumothorax. So only if you show the good, you'll be able to compare that with the patient and let them know what is the bad. Okay, let me just open the chat box. PV, Sachin said, sorry, what? Oh, PV stands for physical examination from examiner. So you have to ask from the examiner. However, there are some stations where they will give you a PV card. So they will tell you PV card given in the station. There's either a card or either you have to ask. If you're asking it, it has to be very, very, very structured. You start from your hemodynamic stability, do your general appearance. If you didn't do hemodynamic stability on top, do your vital signs after your general appearance. Systemically do it and focus from the key. So if it's, as I said, syncope case, you focus on CVS and neuro. Abdo pain case, focus on your abdomen. There are some candidates who have an abdo pain case, but instead of starting with an abdo PE, they start all the way from CVS, respiratory, and then they do abdo. It's very clear cut. You're telling the examiner, I don't know what is needed from me in this station. So please do it very focusedly and systemically and prioritize. Now, when I'm going to talk about diagnosis and differentials, first thing, let me say, some of you guys ask me, how important is it for me to get the right diagnosis? Let me tell you, it depends. As long as it depends on how important is it to get the right diagnosis, because you can only get the diagnosis as well as you have done the history. Okay, let me give an example at this point in time. I think many of you have heard this example before. There's this case on gender dysphoria in AMC clinicals. And what happens in gender dysphoria is you have a patient who is a female who wants to be a male. So his name is Alan. You call him Alan. How about he's in Alexandria? Now, the way to diagnose gender dysphoria is only if you are able to identify that this trait of him wanting to be a man affects his daily living, affects his mood, and causes stress within him. And he has been doing actions. For example, he has been tying his breast. He doesn't want people to see his breast. He has been taking some kind of hormonal pills because he wants to hide the fact that he wants to be a guy. He wants to grow those hair. then you can diagnose someone as gender dysphoria. But if in your history taking, you did not ask a single question about how this gender identity, mismatch of identity is affecting his life, if you diagnose as gender dysphoria, you will be marked down because you did not ask the key questions to diagnose the patient with gender dysphoria. However, if you diagnose the patient with gender incongruence, now that will give you a higher mark. So if you don't identify any kind of stresses in his life or how this is not affecting his daily living, you diagnose the patient with gender incongruence. In order to diagnose someone with gender dysphoria, you need to have in the history that his life is being affected very greatly. All right, let me just open the chat box for a bit. Yeah, so as Prashant was saying, so that is one case where you give a wrong diagnosis or correct diagnosis based on your history. The other one is this. They also look at your differentials very greatly. And I always tell you guys to have a prioritized selection when you're giving your differentials. So let's say let's use the example Prashant gave. So it was lung cancer, and Prashant gave as was atypical pneumonia, you gave diagnosis of lung cancer. But probably correct in your differential. So if your differentials is ranked very well in your top three has your diagnosis and you did very good key questions in the history, the examiner will clear you. Because remember, the goal is not to only get the correct diagnosis. The goal is to have a holistic, non-premature closing station and consult. So there are candidates who be like, yeah, I got the correct answer, love, but I still failed the station. Yeah, that's because you probably missed key questions. You didn't rule out your red flags. And some people will be like, oh yeah, I got a wrong diagnosis, but I did a very good history. I didn't miss any of my red flags. I asked all the key questions. I ranked my differentials really well. I nailed my investigations. Definitely that guy will pass. And the person even who got it right and missed everything else will still fail. It's like how to say that recently there was a story that I heard in a result slip where the candidate passed 9 clinical stations, but overall apparently they didn't pass because approach to patient was failed in every single station. Now, one thing to take note in such a case is that, of course, it feels very unfair. Like if it was me, I'll feel like it's so unfair. I'll be like, well, damn it, I passed every clinical. My clinical is so good, but just because my approach was not good, they failed me. But if you were a manager or if you were a boss of a hospital, would you want to hire someone who is clinically so good but so terrible with your patients? Would you consider hiring them? Would they make a good doctor or would you chase away your patients? Is there room for misdiagnosis and missed diagnosis? You would have your thoughts on them. And if you see another candidate with relatively good clinical skills, maybe not as 100, no, maybe not a 90% like the other candidate, but a 6, but a 70, but really good approach as well, I would definitely pick that candidate over this candidate. So that's why I'm saying both approach to patient is as important as your clinical skills when it comes to the AMC exam. All right. And now when we move on, sorry, okay, let's continue talking about approach to patient first, then I move on to the other task. So for approach to patient, one thing to realize is they look out for whether you are actively listening during the exam. I have a lot of candidates who I will tell you guys, are you smoking? They ask me, and I'm like, yes, I am. Okay, good. Move on. Do you drink alcohol? Okay, move on. So what's the point? You only want to listen to what you want to listen. You're not even listening to your patient. So is that even a history taking? Are you even active listening? Will that give you marks in approach to patient? Unfortunately, it doesn't. Even today, I was doing a session with someone, and we had an MSc station in that exam. And I know how you guys get really stressed when you have an MSc presentation because all you want to do is ask every single question to present your MSc. But you forget that you have a patient in front of you and you still have history taking skills that you are marked on. And that's the reason why many people might pass the MSc, but you will fail the history taking skills. And if the examiner doesn't feel happy, overall, you might not make it through. All right. And one thing I wanted to mention, I'm going to reverse a little bit, guys, very quickly. Let me just reverse here. Now, to get the passing score of 9, yeah, it has to be the global score. So there are stations where I will show you when we look at result slip where candidates pass the predominant assessment area, but they failed the global score of the exam because the examiner just didn't feel like passing them. And there are multiple reasons for why the examiner might not feel like passing you. Probably your approach might have been down, or yes, you hit the predominant assessment area, but there are other red flags you might have missed in the station. So they are different things. So you don't only have to pass the domains in between, you also have to please the examiner, which is why I think if you look on the different group chats, I think George Iskandar is one of the previous past examiners, and he makes it a point to tell you guys to always thank the patient and thank the examiner before you leave that room. That first impression matters a lot. Now, someone asked in the chat what is approach to patient. I will show the results slip later. Every single station has approach to patient. Essentially, it's just whether you're able to hold a rapport with the patient. Are you able to listen very carefully to the patient and do the correct follow-up with the patient? It also talks about how you transition between your tasks. So if for the first task is all about history taking, second task is about diagnosis. Many of you guys just go, okay, so you are having a condition called pneumonia. You're having a condition called placenta previa. That is so abrupt. In a normal day, if you think about it, would you do that with your patients? So you would slowly take your time and be like, well, from after having asked you a couple of questions from the history and also look at the physical examination, the most likely diagnosis that we have is placenta previa or whatever you diagnose with. So don't just jump into going straight into answering the task. Have that transition lines very nicely. There are also many of you who do the rubella case with me, the rubella pregnancy case. And when you do the rubella case from the stem, you will never know that she's pregnant. The only reason why you know she's pregnant is because you know the recall. So people now struggle. They're like, how can I ask about is she pregnant without showing the examiner I know the recall? Because if you show the examiner you know the recall immediately, that is premature closure of the station. And automatically your history goes a little bit downhill from there. So I tell candidates, once you've done your history representing complaint, it's very simple. Tell the patient, I'm going to ask you a little bit questions about your general health. Will that be okay? Because it's okay. Let's start with your period history. When was your last menstrual period? So make it very comfortable. Make your transitions very smooth. And when you are starting your preparation for the AMC, you might think this is not important and you guys do very quick transitions or zero transitions, but you tend to struggle later on when you try to insert these things. So if you have time right now, try to insert the transitions. But of course, don't focus 100% of your energy onto it. There's just 1 or 2 seconds that you need to speak before you move on to the next task. This will increase your score and approach to patient. And as much as we tell people that, or we tell examiners, or we tell the examiners are not very biased, it is human nature. If someone comes to me in the morning session and I look, or maybe even one session before this, and I'm like, wow, she did really well in that case, man. And then I see another candidate in the same case, and I'm like, automatically human mind tends to compare. Of course, as much as they tell us that the examiners are non-biased, they're very neutral, human mind, you can't control. So it is very subjective to the examiner to a certain point. That's why it makes a difference. You have to shine a little bit more better than the previous candidate who has been in that room. And that's why I tell you guys, out of 40 candidates, 30 of us go to almost the same preparation courses that we take. The remaining 10 of us, again, very similar courses because there are very few providers out there for us to prepare for AMC2. But that's where you come in with your individuality and your authenticity, and you add your own things to become a better candidate in the exam. And that really makes a difference because that guarantees you a pass. Okay, I wanted to tap on what else? Management. Okay, so let's talk a little bit about management. The one thing you guys need to know about management is that it includes investigations in management. And when you are thinking about investigations, always ask yourself, am I confirming the diagnosis and am I ruling out the red flags? If your history is able to rule out the differential and it's not a red flag, there is no reason for you to actually do an investigation in the management for that. So for example, there's a case that I've been doing with quite a number of you guys. It's a delirium case. And everyone will ask me, is there any shortness of breath? Is there any cough? Is there any sputum? And I go, no, no, no. So you already know that if it's a delirium with fever case and you're going down for infections and you check for pneumonia, and I give you no shortness of breath, no cough, no sputum, but in the investigations, you're like, I want to do a chest x-ray. And I'm like, why did you do a chest x-ray? No reason. You just confirmed there's no pneumonia. And now you want to do a chest x-ray, over testing. Now, the reason why I'm so particular with choice of investigations is because the first time when I sat for my exam, the reason why I failed was because of choice of investigations. I used to over test all the time. I thought doing everything in the world was the best thing to do. But then when I didn't clear and I saw my result, and I saw, wow, why is choice of investigation so bad for everything? I read the handbook after that and I realized the blunder that I was making. So I'm going to share with you guys a little case. Let me go to the case. I know I have a case for you guys here. Yeah, this one. Okay, so please read this case. Okay, I will share with you the diagnosis, but I just want to focus on the investigations part a little bit. So read the case first. I'll give you the diagnosis. It's a handbook case, by the way. Okay, so now through the in history, you identify that she is having a threatened miscarriage. Okay, and through the second task, right, from task 2 under general and the PFI basically, you identify that the os is closed, right? So you know it's threatened miscarriage. Now your task is this. Can you in the chat box now tell me the investigations that you would like to do for this station? Okay, so we're going to do task number 3, just the investigations part. What are the investigations you would consider doing, knowing that this is a threatened miscarriage? In the chat box, everybody. Okay. Yes, beta HCG. More important people, beta HCG. Okay, ultrasound. Okay. Mm-hmm. Okay. Good, good, good. Not too bad. The previous time when we did this, you guys are really smart. Okay, the previous time, let me show you the answer first. The previous time I remember doing this is a few of them asked for coagulation panel. And then my question was, why do you need a coagulation panel if you know that she's bleeding because of a threatened miscarriage? Yeah, blood group will be important as well. These are the answers, guys. So in the handbook, you'll realize that these are critical errors. If you do not hit them right, you will fail the station. And this station has come out in the exam before. And I have told candidates who want to reappeal to come back and look at this case and be like, if you didn't ask this, don't bother. And some of them are like, yeah, love, I forgot to ask beta HCG because you assume that she's pregnant. You don't confirm it using a pregnancy testing. It is a critical error and you will fail the station. So these are things to look out for. And to also check the visibility. So if it's a complete miscarriage, then you would not really need to check the visibility of the pregnancy because you know that there's nothing in there. You probably just need to do a DNC and clear out. But if it's a threatened miscarriage, the baby is still inside and you need to check what is going on inside. So different types of miscarriages, there's a little bit of different investigations that you need to work on. So please read the guidelines. Please read John Murtak. And if you're looking, example, you do this case today. After today, let's say you go to the handbook, you want to practice this case with your partner. Read the guidelines for all the different miscarriages. Don't just only read on threatened miscarriage. Take some time, explore, and go beyond. And then after you do this, you'll be so good in all your miscarriages. You don't have to revisit it so quickly. Maybe a month later, you can revisit and you'll be done. So that is what I wanted to mention to you about choice of investigations. Very, very important. So please do that. And when it comes to differential diagnosis, let me reverse back and do differential diagnosis a little bit. Okay, I'm going to talk a little bit about differential diagnosis for a bit. So I explained to you choice of investigations. Now, when it comes to differential diagnosis, it is very, very, very important to, now this is new word that I learned, right? It's called prioritize selection. It is in the tips from examiner sheet that the AMC has released. You can find this in the AMC website, okay? Tips from examiner. And let me just give you a couple of examples on what I mean when I talk about differentials in prioritized selection. So if you have a patient who's coming to you with headache, all right, patient is 30 years old. If someone is 30 years old, I am not going to put temporal arteritis as my first differential because you know that temporal arteritis is something that happens above 50. So the examiner will know that this candidate is just throwing out differentials without thinking, and they're just trying to complete the list as much as possible. So that is not your approach. Your approach should be thinking that, hey, okay, tension headache, a little bit higher. Of course, your red flags are high up there. So meningitis, meningococcemia, brain tumor, you put them up there and then rank them accordingly to the situation that you have at hand. So if you think that she probably had a viral flu recently, okay, fine, sinusitis, cluster headache, a little bit more higher compared to a brain tumor because she doesn't have the early morning headache. She doesn't have the early morning vomiting and chronic headache. It's not going to be brain tumor. I mean, not as high as compared to the other ones, but you would still mention brain tumor and meningitis because they are red flags in a headache case. Likewise, if you have a station of secondary amenorrhea, a lot of you guys like to tell me that she's having menopause. I give you a 19-year-old female with secondary amenorrhea. You're telling me that menopause is your first differential. Doesn't make sense, guys. Go for better differentials, more closer. Athletic amenorrhea, eating disorders, pregnancy, number one cause of secondary amenorrhea. So think about your differentials according to the history that you have gotten. All right? That's what you have to do. And for example, if some of you tell me that, love, am I marked for my task or am I marked for the answers that I give? So let me explain clearly. There are some places where there's no task for give your differentials. But then when the result slip comes, you will be marked on differentials. So what does that mean? That means you have to ask that key question for that differential in your history. So in a chest pain case, if you want to rule out pericarditis, you ask, any pain on leaning forward, any previous flu-like symptoms that you had, or if you want to rule out pneumothorax, be very clear. Did you have any kind of injury to your chest area? Was it a very sudden kind of chest pain? Do you have any shortness of breath alongside with it? Make it very clear to the examiner what differential diagnosis you're ruling out, because that's how they score you for differential diagnosis in a station where there is no specific task to label the differentials. But there are some stations which come with history, and then your second or third task will be what are your differentials. Now, in this task, remember, history is marked separately. Task 3 is marked separately. You here have to give your prioritized selection with as many differentials as possible. So even if you didn't ask the question, so even if you didn't ask the pericarditis question, still go and tell them pericarditis is one of your differential for chest pain. Still go tell them about pneumothorax, even though you didn't ask those key questions, because you are marked with a number of differentials based on the history of presenting complaint. Because there are some of you as well, I do stations with you guys. History of presenting complaint will be itch. And then you, in the middle of the story, you identify that it's a rash. And then you end up giving me fever and rash differentials for the case. And I'm like, no, but wait, your history of presenting complaint was itchy. It was not fever and rash. So be very careful when you're giving your differentials. Look accordingly and give it just to the history of presenting complaint. Now, I got a question in the chat box. How many DDX to rule ideally when taking history? I would say 5 to 7 is good. 5 to 7 is very good. And then when you are mentioning them, 7 and above. The reason is this, even when I do cases with you guys, I'm busy writing down, right? I actually miss something that you guys tell me. So if you guys tell me 5, I probably only caught 4. And you might only get marks for 4. Human error. You have to give room for human error here. If I make the error, I'm very sure these examiners who are like way older than me and who have been seeing 20 other people before you, they probably might make a similar mistake. It's not their fault. It's just human error. You can't avoid that. So please push your differentials up to 7 and above. And some of you guys ask me, if you are diagnosing someone with a particular condition, so for example, let's take meningitis, very easy one. If you want to diagnose someone with meningitis, make sure you ask about the fever, ask about the neck stiffness, ask about the sick contact, ask about rash. Ask all of this to confirm your diagnosis. So 3 to 5 questions if you are diagnosing someone with that. You can't just say, oh yeah, this person has rash and fever, therefore equals to meningitis. You're not going to get any mark. There's no any kind of diagnostic formulation in that, because fever plus rash can mean so many things. How do you know this patient has meningitis? So ask 3 to 5 questions if you want to confirm a diagnosis. If it's a red flag, all right? If it's a red flag, for example, let's take chest pain GERD, okay? Chest pain GERD, but MI is a red flag here. If you want to rule out MI, ask your MI symptoms and then ask at least 2 or 3 symptoms if it's a red flag that you're trying to rule out in the station. So if you want to confirm a diagnosis, 3 to 5 questions. If it's a red flag, you want to rule out 2 to 3 questions. If it's just a system or diagnosis you just want to pass on very quickly, 1 question enough, guys. If you want to rule out thyroid, any weather preferences? No. Okay, thyroid out of the way, kick it out. So if it's just a differential, very quick one. Just do one, 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 one. If you want to be extra, you can do 2 for that. Which is why I tell you guys, when you are studying, look at a cluster, look at the differentials, know the key positive findings and key questions for the differentials. It is just not important to know, oh, I know headache. Headache has 11 differentials. I know all of it. That's not going to get you much marks. Yeah, fantastic. You remember them, but you need to remember how they can be because you have tasks which says differentials with reasons. And if you're not fast enough to know why these are not my diagnosis, you will take forever to think about it. And I told you, this exam, there is no time to think inside. All your thinking, all your planning, all your strategizing done before the exam. You only have time to go in and execute. You only have time to stand outside in that 2 minutes to be like, okay, what are the key things I can't forget? What are the history structure points I'm going to bring into this station? That's all you have in that 2 minutes. In fact, later when I share with you guys a little bit more, you'll realize that it's actually not 2 minutes that you have. It's only about a minute-ish that you have. Okay? So let me move on. We did this, we did this, we did this. All right, how does the scoring work? Okay, so any questions from about the domains that exist? I will be showing you result slips so you guys can look at domains a little bit more and then you can ask questions if you have any questions about domains. Now, each domain can be scored up to 7 points and you need a 4 points in global ratings. This is where I tell you, you need to impress the examiner of yours. You need to give that extra cream and the sprinkles so that the examiner will remember you and be like, this candidate, pass. I don't have to think. You have to tell them that when you go in, it should be like, I'm going to use Prashant, I'm going to use your name, okay? So, this Dr. Prashant, this is a confirmed pass, no room for failure. That's the impression you should give. You should not give that doubt to the examiner, all right? Now, these are some examples that I have. Yes, Prashant, that's what you're aiming for. Okay, 777. Now, here in this station, it is a health review. Health reviews, a couple of you guys have asked me before. It is usually a counseling station. It can be smoking, it can be alcohol, it can be marijuana, heroin, usually a counseling station. MSM, FSF sometimes can come as a health review. If not, they will tell you STIs at the top when you get the scenario. So for those of you who haven't seen results before, predominant assessment area right on top tells you management, counseling, and education is your predominant assessment area. History, patient counseling, management plan, approach to patient. You need to pass. Usually they expect you to pass all of it. Okay, this is how it looks like. This is a very good candidate. Your goal should be this, everybody. Look for this, aim this, get this. All right. And I've always told you guys, do not aim for 4. Do not aim to get 4 points. Do not aim to get 9 stations. Your goal should be at least aim for 11, 12, 13, guys. You fall a little bit lower. You fall into 10 and 11. Still okay. You fall into 9. Full stop. Okay. And if you realize, I don't see many candidates getting 9 actually. Most of them get either 11 or 10 and above. A very little 9, which means you need to show a good pass overall in order to pass this exam. Now, the other one I want to show you is this. Some people ask me, Love, how important is predominant assessment area? So if you look at this station, yes, it can be very important. The candidate here did not do well in the management counseling education part, even though the other parts were quite well done. In fact, you get a 5, I will tell you, very good job. 5, 6, 7, fantastic actually. So 2, everything overall is a fail. Why I picked all management counseling? I think because the results slip looked a bit more interesting. Sorry, guys. I do have PE stations later on. Okay, even here, if you see, candidate did very, very, very well in everything, but just because management plan becomes a 3, overall you fail the station. So very unfortunate because these are actually quite strong candidates. They are strong candidates. They either pass, they either fail with the 8 station. And this is the kind of mess that they find themselves in at the end of the day. And if you do realize the task these days are turning towards management more than your history taking emphasis, which is why my PDA has a lot of management these days, unfortunately. So please, please, please work on your management. If you study a cluster, if you study a differential, open, check RCH guidelines for pediatrics, go into health pathways, check Australian guidelines, learn the management a little bit. I'm not asking you to be very in depth in them, but know the basic and the red flags that you need to tap on the management before you move on. All right. Then let me show you. Okay, this is how physical examination stations are. All right. And okay, let me reverse a little bit. So physical examinations people can come in a few different ways. One, the STEM can already tell you that this diagnosis is given, which means pneumothorax is given, heart failure is given, uh, preeclampsia is already given. So when you do such examinations, you should be able to know all the positives the diagnosis is given. So heart failure, you should know your bibasal craps. You should know any kind of pulmonary edema. You need to look out for a pitting edema in the legs. You need to look for JVP. You need to look for hepatojugular reflex. You need to know this back at the top of your fingertips. You can't take time to know this. If it's a pneumothorax, automatically you must know. I'm going to look for tracheal deviation. I'm going to look for air entries not bilaterally equal. I'm going to look for hyperresonance on one of these sides, on percussion. It should be like that coming to you. So that is if a diagnosis is given to you, you pinpoint all your positive findings. However, in recent times, the stations are changing. You are having stations based on symptoms. So in this particular case, this was my exam. It was a tingling and numbing. So it was the patient came with tingling, if I'm not wrong. And in this station, patient came with tingling in the hands. Of course, you do think of symptoms like carpal tunnel syndrome, ulnar entrapment, and all of those. So if a symptom is given, think about all the possible diagnosis and all the possible presentations the diagnosis can come with. So what I think I did extra here compared to a lot of other friends that I talked about was that I knew that numbness also can be a result of hypocalcemia. So a little bit far, but possible. I looked out for any kind of thyroid surgeries in the general appearance. So, and I went for the GA, I was like, I'm looking for any kind of thyroid surgeries just in case the parathyroid gland has been removed, leading to hypocalcemia, leading to numbness or tingling sensation. So you have to be very wide when a symptom is given to you. You need to think from all different angles on what the possible diagnosis can be, and then the presentations that you get. So it is harder than the other station, but this one is increasing in recent times. They want you to be very wide. So please work on physical examination. It is a very easy station to score as long as you show that you are confident and you have a structure. And yes, they do look at differential diagnosis. You are scored on differential diagnosis if usually a symptom is given to you. All right. Now, the other one is a diagnostic formulation case. If I'm not wrong, this case was a vaginal bleeding. It was I think threatened miscarriage case, if I'm not wrong. So this is another predominant assessment area that you get. And one thing, if you read at the bottom of the slide, if a domain score of 0 is given when you don't assess or you don't answer a particular task. So for example, the task at the end says management, but you run out of time and you don't address management, automatically it's a 0 and you might fail the station. So please work on time management, get that inner clock ticking, and answer all the tasks. Read the task very carefully. Many of you ask me, can I finish the exam in time? Answer is yes, because these stations have been piloted by the AMC. They know that these stations can be finished in 8 minutes. They also know that you will never really need a supervisor because every station given in the AMC exam can be handled by a junior medical officer or a RMO. You don't need a supervisor to come saving you. So please, if you are the person or the candidate who always says, I'm going to get my supervisor, I'm going to involve this person, no. Okay, you should be able to solve the case on your own. It is very obvious when you start calling for help you don't really know what's going on. Now, many of you ask me, if I pass dominant assessment area love, does that mean I pass everything? Do I pass the station? Unfortunately, please look here. No, history got 5. I don't know what this case is. can't remember whose one is this as well. So history is a 5. That was the predominant assessment area, but everything else was sub, not really fantastic. So they won't pass. So it is not, I think even recently, if you guys have been following the group chat, one of the doctors at a station like this as well. He passed both the predominant assessment area with 4 and 4, but he failed overall globally. So those things happens, guys. So when you go to a station, you will never know what the predominant assessment area is. Just enter the station, give it your best shot, be holistic. I'm sure the station will favor you. All right. Any questions so far about predominant assessment area and task in the AMC exam? If not, I will move on to resources. Okay. Now, the number one resource that I recommend is the AMC Handbook, everybody. It's the best resource. However, it was produced 20 years ago, if I'm not wrong, I think 2007 maybe it was produced. So please, management might have changed in certain things due to guidelines. Otherwise, history is still the same. History doesn't really change over the years. It is still the golden book. I'm going to run through with you very quickly on how to use the handbook because many of you guys do not like the handbook because you think it's so wordy and you don't understand what's going on. I currently now run handbook sessions once or twice a month. So please join them. This one is a very quick one for those of you who do not know how to use the handbook. If not, I have a YouTube channel. So please go to that channel and watch my handbook sessions. I have handbook session 1 and handbook session 2. So this is a typical station. It's a tension headache station. So when you read, please read the different tasks because this is exactly how you will have these stations in your AMC exam. It can be quite stressful. It can be quite a lot. All right. 2 minutes reading time, 8 minutes presentation time. That's always the situation. Dr. Sunny, what is PD? No, you will never know which one is your predominant assessment area, unfortunately. However, sorry, let me just answer the question in the chat box first. Now I'll come back to this. However, if history is given 7 minutes or 6 minutes, most likely that is the predominant assessment area, history. But the others, very hard to tell. I have tried. I can never find out until the day comes. So until the result slip comes, you'll never know. So we can't play that trick with them. And in fact, in 2 minutes, your brain won't even work to think like, oh, this is the predominant assessment area. No time. You only have time to think and enter the exam. So 2 minutes reading time, people, 8 minutes presentation time. Now, for some of you guys who are going towards your exam, if you just started out your exam or practicing revision, take 2 minutes and take 8 minutes. However, as you go towards your exam date gets closer, please cut down. Okay, the lowest I would like you to cut to is 1 minute 30 seconds for reading and 7 minutes 30 seconds for presentation time. Reason is because anxiety happens. Okay, sometimes you might be cheering. You can't even read the stem at 2 minutes. I was cheering in one of my stations. When I came out, I couldn't even read my stem. So I had to wipe my tears and read my stem. So it's not your fault. I just couldn't see. My eyes were so blurred. So that happens in life. So give room for anxiety, give room for mess ups. And sometimes you're reading the stem of the station number 10. Suddenly you are thinking, I should have said that in station number 5. So you need to give time for all of this. Buffer yourself. So practice with 1 minute 30 seconds when you have about 1 month towards your exam and 7 minutes 30 seconds for presentation. Why 7 minutes 30 seconds? Reason is because you enter the station, examiner is going to check your ID. Examiner is going to ask you to sanitize your hands. Now, with regards to sanitizing your hands, in May, the sanitizers were not working, so they stopped asking you to sanitize. But in June, they got the sanitizers to work back up again, so you had to sanitize your hands in every station. So please be careful when it comes to that. And then you have to greet the patient and all of that. So cut to 7 minutes 30 seconds. Try to finish it as soon as possible. Okay, so for the handbook, this is how you use it. When you do the handbook, it's one of the best ways. Please do not use recalls to practice your role play partners because I can never understand how you guys know the exact story to give in the history. But if you practice with your role play partners, the handbook has the candidate version and the exam and the role player version. You will exactly know what to say, how to think, and how to structure your consult and what the answers the AMC is expecting from the candidate. So as you see here, if you do a Sikora or Socrates for a headache station, you should be able to nail everything in the history here. And if you are trying to diagnose someone with a tension headache, you must 100% identify the psychosocial and environmental factors. If not, you're not going to pass the case. And if you don't if you don't rule out meningitis, if you don't rule out benign intracranial hypertension or any ICP increase, again, unlikely because these are red flags. That's how the handbook actually helps you. Look at the key issues, look at the critical errors. Please avoid all of them. Oh, Swati left, no worries. Okay. Now, this is one of the I've sent this to you guys before. I don't know if there are new people in the group, but this is actually present in the group and it's also present in the Google Drive link. So what I have done previously when I studied was I wrote the case here at the side, the case number, and I used to write the key points that I need to know. So because you remember, it's 2 weeks before the exam, you can't expect yourself to flip through the handbook. You need to start for newbies, for new people especially. This is your time to start preparing the resources that you want to use 2 weeks before your exam to make sure that 2 weeks before, all I'm going to do is look at this. So this is something that you would like to do if you want, if it works for you. I just have all the critical errors and red flags. So I know that every vertigo case that I get, I run through my structure first, I rule out my differentials, then I read this here. And I'm like, okay, I cannot miss this investigation. I cannot miss this critical error. Okay, I need to check for pica syndrome because it's a red flag as well. And I think I have this for about 60 over cases in the handbook that I've broken down on key points to have. Of course, if you do it by yourself, it'll be easier because, again, the brain remembers the process more than the result of something. So the brain will remember you working hard to read and study and then do this chart by yourself. If I give you and I spoon feed you the chart, well, it wouldn't be as 100% effective. Maybe just 10% or 20% effective because the answers came to you. Your brain is not going to remember. And I also always tell you guys, the brain remembers the last time it tried to remember something. So keep on reminding yourself and re-looking at previous cases because that's the only thing your brain will remember. It doesn't remember what happened 10 years ago. It remembers the last time you thought about it. That's how our brain works. So you have to know how your body works for the exam to strategize to enter this exam. Okay, and then we're going to move on to what's in the chat box. Is it in this group? Yes, if you are in the AMC Clinical's Hustle Hub group, you would have this file. I have sent this file, I think 2 or 3 times, multiple times, in fact. You would have it. If not, I will send all the links later to join the group and I'll resend all the resources, so not a problem. Now, the other resource you want to use, I'm very sure AMC Part 1, most of us would have used this. This is still one of the better ones in the AMC exam. It is really good because, but for those of you who have never opened this book, please, it's a colored book, okay? It's a colored book. It's written by one of the top GPs present in Australia. So don't run away from it. It gives you your definitions, investigations, triads as well. I enjoy it because it helps me think. It helps me understand things a little bit better. But of course, if you only have 2 months to go for the exam, I would say you don't have a lot of time. So maybe just scan through and refer to Murtak. Don't sit down and study. That book is really, really big, more than 3,000 over pages or 5,000 over pages. So no point. But if you are someone who didn't get a date this time around, you want to think of getting a date, maybe in the next sitting in March, then slowly read back this book. Okay. The other one for resources for physical examination, best one is Telly O'Connor, guys. I've always told you guys, Telly. Geeky Medic for videos. And there are also more resources present on the AMC website for physical examination. Okay, now we're gonna zoom into how the exam is on that day very quickly. So this is how the exam is on that day. For those of you who have your exams really soon, this will be very, very beneficial for you. So the registration starts. Usually you're waiting in the first floor and then a marshal comes and picks you up and then you go up for registration. I think the third floor for the exam. You need 2 identifiers. Do not forget them. Try to bring your own stethoscope. I always say that because you might panic when you don't have a stethoscope or you don't know how to use it. It might be different. You're very comfortable with your stethoscope. You will also be given a lanyard during the exam with your starting station and your face and your candidate number as well. And then you will be then sent to a locker to put all your different things or whatever things that you have into the locker. Once that is done, so if you are very early, you sign in first. Unfortunately, you still have to wait for all 20 candidates to come in. When you are waiting in the area of the holding site, you are able to drink water, you can take snacks, you can even hold your physical notes, so no digital, but hold physical notes. You can do that. So if you have papers, fantastic. But of course, I will always remind you guys to be calm, breathe, chill a little bit. Okay, just calm down. Let the brain chill, don't overstress your brain. And the one thing that I always mention to you guys, especially in the waiting area downstairs, so not the waiting area in the exam level, but in the first floor, try not talking so much to other candidates, not because you're unfriendly. Okay, I'm a very pro-friendly person. I love socializing, but when you start talking to all of them, they stress you up sometimes because they're all under pressure as well. They're all under stress. They start asking you for mnemonics. They start looking at recalls. Okay. Your brain will start panicking, like, oh man, I don't remember that. I don't remember the mnemonic. Oh man, I don't remember this investigation. You're gonna panic. So chill, try to avoid have light conversations, friendly ones, but avoid those people who come and be like, what is the answer? Do you know this? Do you know that? So don't. Okay. So just be careful. And yes, I saw the situation of the date yesterday in the chat box. So waiting area, I've talked. Now the exam. So I do have a image in the second slide. So you'll be given 1 to 20, number 1 to 20, and this is how it will be here. Okay, so of course 1 to 10 on one side, 11 to 12 on this side of the exam. So you stand in front of your exam, you enter the room, come out, you go to room 2, go out, go to room 3. That's how it's going to be, always moving in this way. Now, what happens is this now. You are given 2 minutes reading time, and let me tell you, it is only in the first station you are given 2 minutes. Because when you have entered room number 1, when the 8 minutes ends, well, you might still be pushing in your chair, you might still be thanking the patient. When that 8 minutes ends, the 2 minutes for your next station is already started. So you might be still inside the room, but your 2 minutes reading time is already started, which is why I force you guys to go for 1 minute 30 seconds if you're about 1 month or 3 weeks away from your exam. Because you have that cut of time, you have to come out of that room, enter the next, go to the side and look at the screen. You also emotionally, you will be a bit stressed as well. So cut down your timing. And 8 minutes presentation time, you usually always get 8 minutes. Okay. So I did this. Now in the room, how was it like? All right. So before sharing the layout, let me just share with you what is inside the room. So you have there's a very big TV screen in the room with the STEM and the task. So you can always refer to that. You also have a printed task and sheet, hard copy on the table for those of you who are short-sighted or long-sighted. They have everything for you right there. Okay. They also have a paper and pen for you. So again, you can't write in your 2 minutes. You can only write once you're inside the room in the station. Okay, and then you would have, now let me show how the room looks like. So this is the door, guys. Okay, the 2 X's here. The 2 X's are actually the sanitizers. In some rooms, of course, it's not there's 2 sanitizers. Some sanitizers are behind the door, some is on the other side of it. So please check where the sanitizers are if the examiner says, please sanitize your hands. This is where your table will be. All right, this is the screen where I said the screen with the STEM and task will be here. You will be happily seated here. The role player will be here. By far, the setup is still the same over the many, many weeks and many, many months. Okay. Examiner will be behind you. So the only time you have eye contact with the examiner is at the beginning when you are giving your ID and doing your introduction. Otherwise, if there's no specific task that says from examiner, you will not really have to talk to the examiner. You're always talking to the patient. However, if you have to talk to the examiner, please rotate your chair, turn, have good eye contact, smile, and then talk. You need to buff up your points, guys. Can't afford to fall below that 4, all right? Okay. Any other questions in the chat box? Let me see. Okay, you guys are so funny. Okay, any other questions that you guys have for me? That I think that will be the end. I think I have for you guys to share on Introduction to AMC 2. I'll put this slide on while I answer the other questions. So, Dr. Yudi, Dr. Yudi, did you get a date in the end? But yes, so far, the first time when I booked my exam, well, there were more options when during the booking time. So I booked it in about 2 minutes. I got about 2 minutes or 3 minutes to book. Again, you don't have a lot of time. The second time when I booked my exam, it was harder as well. But I think before 1 minute I was able to book because I was in Australia then. The first time I was in Australia, so internet actually really matters a tad bit. So please use your data for the next time round. But I'm very sure the next sitting there'll be way more dates, guys. To be very, very, oh, you didn't get a date. Yeah, there'll be way more dates the next time round. And for those of you guys who didn't get a date, all right, but you've already started your preparation, like Dr. Yudi, attend this session. I always say that I think I sent a quote in the group chat saying that mend your fish nets. You know, fishermen mend their nets even when they can't go to sea. So I do have a lot of trial exams. So if you want to be a role player for those trial exams, hit me up, drop me a text, and I'll let you know when the trial exams are coming up. And then you can be role player for the first four stations. So when you do that, you're able to understand the case, you know the positives, you are still in the loop of in touch with AMC. Then when you finally get a date, so maybe you can just do it like once in 2 months or once in 3 months. And when you finally get a date, you can go hardcore studying and you can then practice on your own. So let me know if you guys need to be involved as a role player in trial exams. It will help you guys. And of course, you will be there for the feedback as well. I always include you guys in the feedback because you need to understand how every case is broken down. If not, any particular questions, there are handbook sessions for everybody. So I think the next one is in about 2 or 3 weeks' time. I'll conduct another handbook session. Um, Otherwise, I do have some links. If you guys are not in the group chat, I think there's a group. Let me just make this small a little bit. There is a group chat that I have. I don't know if you guys are inside it, but I will send the link for that in a bit. It's the group chat. And any questions? If no questions, then I will stop the recording for a bit and I'll send you guys